So now this is Learning Plan 2, Manage Care for Patients Experiencing Anxiety Disorders. So Chapter 10 in Varkarolis is Stress Responses and Stress Management. So before we even start talking about stress responses and different theories where we really kind of pull our information from, it's probably just a good idea to stop and just think for a minute about the effect of stress and that you will be taking care of patients in a hospital setting, and not only in mental health, but in any setting that you work in, you will be encountering patients that are having bad responses perhaps to stress. And stress and anxiety are just really part of the human condition. I really like on page 157, the very beginning of the paragraph in Varkarolis talks about just how essential it is to understand psychiatric disorders as far as mental health, providing mental health care. We really have to have a good understanding of anxiety because, yes, there are specific anxiety disorders, but anxiety is a comorbidity for almost every disorder that I'll be talking about for the next several learning plans. Truly, anxiety is a comorbidity of depression, schizophrenia, substance abuse disorders, personality disorders, eating disorders, pretty much everything. And it's just, again, really part of the human condition. So I would be really surprised if any of you said that you never experienced anxiety before, that you just truly didn't know what that was like. And I think that all of us have experienced anxiety to one extent or another. Some of us experience it more, and some experience it a little bit less. Again, going back to what I had said in the very beginning of Learning Plan 1, everything's on a continuum. So some people are higher on the continuum just naturally with their anxiety level, and some people are lower on the continuum, but stress is something that can happen that can elevate raise your anxiety level up on that continuum. So I think as I think about myself, I can probably say, I hate to say this because, you're nursing students, and I just hate to say this, but I probably experienced the worst anxiety in my life when I was in school. Maybe that makes you feel better because you're thinking, oh, good, that, yeah, it's normal. It's kind of natural to experience anxiety, even if you're not necessarily an anxious person. And even if you have a diagnosable anxiety disorder, or if you don't, sometimes certain situations can just bring on more anxiety. So nursing school just might be one of those. Anyways, but there are ways, the good news is that there are ways to cope with anxiety. And so it's not like it's not something that's hopeless. It's just something that maybe some of us have to work on a little bit. I really like, again, the paragraph that talks about that we seem to like this phrase lately in our lives, and it says, what doesn't kill you makes you stronger. And that really isn't true when it comes to anxiety disorders. Theoretically, it sounds nice and there is some truth to that, whereas if you go through things that are difficult and you overcome them, you do feel that you grow and you're stronger as a person. But also, we have to think on the other hand, we really have to think about people that have early exposure to stressful events, especially when we think about kids who are perhaps abused or neglected or just are really living in very difficult situations. And they, that early exposure to stress actually sensitizes people to respond negatively to stress in later life. So it really isn't, that's a great saying, what doesn't kill you makes you stronger, but it doesn't necessarily apply when we think about psychiatric disorders. And also children that do have higher levels of stress, especially during their very, different sensitive developmental phases, they have a greater incidence of having mental illness as adults. So yeah, we do need some stress in our life. It is certainly necessary to growth and change and productivity and all that. But it certainly can make some people lead very, very difficult lives. So I'm not going to be testing you specifically on Walter Cannon, fight or flight, things like that. And maybe these are some theories that you've kind of heard about if you've taken a psychology class either in high school or in college. But the fight or flight, when you kind of prepare for a situation that the individual perceives as a threat to survival, you're going to stay and fight if you feel like you can, or if you feel like you have to save your life, or run away from the situation. So that fight or flight. New research indicates that men and women actually have different neural responses to stress, which just adds another kind of a different layer to to us thinking about stress. And especially then we're always thinking about how we're going to apply this information to taking care of patients. Patients in the hospital are definitely going through stress. And again, patients can be in a mental health setting, they can be in a nursing home, they can be in OB and med surge, outpatient areas. Probably the only area maybe that you won't have to deal with patient stress is actually if you work in the operating room and they're under anesthesia. You're probably not going to be, you're not going to be directly dealing with their reaction to stress. But prior to that, when you're on the surgical floor and you're taking care of them post-op and then pre-op and then post-op, they may have different levels of anxiety, especially pre-op. Before the operation, there's all kinds of anxiety about what's going to happen. Is everything going to go okay? Am I going to live? Am I going to die? Am I going to be disfigured? We all always have different types of thoughts and feelings when it comes to medical events. And think about the person who comes to the emergency room with any type of, difficulty breathing, chest pain, any type of trauma. Perhaps they've been in an accident. So those are always situations that we have to think about where people have anxiety levels, and they're certainly responding to stress in many different ways. So Hans Selye is another theorist, the general adaptation syndrome, the alarm or acute stress stage, the resistance or adaptation, or the exhaustion stage. Just the important thing to think about with this, again, I'm not going to be asking you direct test questions about like naming the theory or the different aspects of the theory, but if we think about how people respond to stress, that at first you're kind of the alarm stage, you're heightened, you're reacting to whatever the stressful situation is, and then you kind of adapt to the stress over time. But if the stress continues, and usually you're hoping that the stress is short-lived and it's something that's going to terminate and you won't be having to continuously deal with it. When you reach the exhaustion stage, that's actually when death can occur if stress is continuous and prolonged. So again, just some basic theory background just to start us thinking about it. The other thing to think about is bad stress versus good stress. So distress versus eustress. So you might be familiar with these terms, maybe not, but distress is any type of stressful situation that's negative, draining of energy, resulting in anxiety, depression, fatigue, and stressors include losses, different types of demands. Maybe you have to perform or demand, somebody is demanding something of you that is beyond your capabilities, things that you worry about, fears, all those types of things really can be very draining and again decrease your energy level, and all of a sudden you're just fatigued, you're completely exhausted because of the way that the stress is impacting your psychological and physical body. Eustress is more positive. It's kind of that beneficial energy that motivates and results in hope, joy, purposeful movement, and it's uplifting, fun, fulfilling events. Any of those things can be causes of eustress. So think about events like the birth of a child, a vacation, a favorite physical activity, getting married, getting engaged. All of those things are eustress. And actually, going to school can truly be considered eustress because you are engaging in purposeful activity and you've got a goal in mind and you are slowly but surely reaching that goal. So that could actually be an example of eustress also. So we have neurotransmitter stress responses, serotonin synthesis, and the thing to really think about this, there are a lot of really complicated chemical reactions that take place in our body, and to expect you to have that all memorized and to know exactly what parts of the brain, I don't think that that's really useful. I don't think that you will have an NCLEX test question on the neurotransmitters, but overall, we should probably be at least aware of the neurotransmitters, and because that's how the medications for depression, anxiety, schizophrenia, many of the mental illnesses, the medications are working on different types of neurotransmitters in the brain. So that aspect of it is kind of important to know, but it is really pretty complicated as far as the whole biochemical response to stress. It is important to note that stress is very, very difficult on every single part of the body. And if you actually look at page 158, there is like a little diagram. It's called the stress response. And you can kind of see the short-term and the long-term effects of stress and what different parts of the body are actually affected. So, for example, I'm not going to read the whole thing. You can certainly look at that page in Varkarolis. But an example is the short-term effects are like fluid loss, inflammation, brain decreased brain norepinephrine, things like that. Long-term effects would be perhaps immune system compromise, depression, atherosclerosis, high blood pressure. So it's not just psychological responses to stress, but actual physical responses. So again, I'll just let you kind of look over what some of those short and long-term effects, and again, we really have to think about whole body effects when we think about stress. So it is interesting. There's more and more research being done, it seems like, about the immune system stress responses. And there is an interaction between the nervous system and the immune system during the alarm phase of the general adaptation syndrome. So what's interesting about that is if you think about yourself even, and when you're in the throes of the semester and you've got care plans and exams and 2 courses and maybe a skills checkoff due or something all at once in 1 week, and you're just feeling like you're running on nothing, no sleep, you're running on caffeine, hardly any food, no sleep, and you're just so stressed and you just don't know how you're going to get everything all done. Think about how many students start to get sick. You get physically sick. Your immune system is really pretty run down at that point. Certainly part of that is you're not taking care of yourself physically either when you're in periods of high stress like that. It seems like I notice that every semester when, especially not over the summer as much, but during the school year when, when you're taking multiple courses at a time and things are all due at the same time. Which actually brings me to a good point. If you do have any time during the semester or even during this online course where you kind of feel like things are piling up on you, and or during the school year when you're taking multiple courses and you just feel like you can't handle one more thing, it's always a good idea to try to do something about that. So, and that doesn't mean just like stay up later and drink more caffeine. It means actually sometimes it's really helpful to talk to your instructor and see if there's anything that we can do. There are times that we can move due dates around a little bit, based on the amount of things that you have due in 1 week. So, yeah, I could have probably said that maybe more in the beginning, but this is probably a good learning plan to discuss things like that. So definitely always keep in touch with your instructor if you feel like you've got some stressful situation going on, and you're falling behind, or you just can't, you have too many things due in 1 week. Definitely talk to us and we'll see what we can work out. It is possible to change things around or whatever. So give you some support for sure. But anyways, but we do have to think about how the this that having so much stress can really negatively affect the body's ability to produce protective factors. So the protective factors are the things that are going to help us to keep healthy and to prevent us from getting sick. And this is really a very complicated topic. And so I just want to point out a couple more things in your book. On page 160, there is a table, 10.1, and it's called Some Reactions to Acute and Prolonged Chronic Stress. So again, it looks at acute and chronic and just some changes that people can have, from uneasiness and concern, sadness, some loss of appetite, all the way to anxiety, panic attacks, depression, anorexia or overeating, lowered resistance to infections, amenorrhea, loss of sex drive, all different types of things, respiratory issues, cardiopulmonary. So just good to kind of get a good basic understanding. And then there's also on page 161 another just kind of a bodily picture. And if you do look at if you do look at this diagram, it is very, I'm sure that if you've been through any type of stress, that you can look at that diagram and say, oh yeah, I get headaches when I'm under stress. I get more asthma attacks. I have digestive issues. I have, if you have diabetes, your blood glucose climbs. I don't sleep as well. You can just kind of go through the whole list and kind of think, yep, I can relate to some of this backache some people have. Rapid breathing, so all different types of things that really, stress really does wreak havoc on the body. So, mediators of the stress response. So, we've got physical and psychological stressors. And so, some of those, okay, I got interrupted. Anyways, physical and psychological. So some examples of physical or physiologic, they call it in your book on page 160, would be, think about your patient in the hospital. So sometimes environmental conditions, excessive heat or cold, trauma, pain, infection, hemorrhage, hunger, any of those things can be considered physical stressors. And those, again, it's not an all-inclusive list. You may even be thinking of some other things yourself. So psychological stressors could be events in a person's life like divorce, loss of a job, unmanageable death of a loved one, retirement, fear of a terrorist attack. Certainly, we're more and more concerned about school shootings and other types of random shootings in different places, movie theaters, malls, things like that. So any of those things can be considered stressors. And again, it's not an all-inclusive list. There's lots of things that we could think of as far as physical or psychological stressors. Your perception is something that is going to mediate that stress response. So it's something that maybe really upsets you is not going to upset somebody else. We're all different. We're all unique individuals. So that is something to keep in mind when you're taking care of your patient. So you may think, oh, well, that wouldn't really be a big deal for me, but maybe it is for them. So it's always the perception, the way that the person deals with that situation or the meaning of the situation to them. So perhaps for you, it's really not a big deal, but for them, perhaps it means like the end of their life, So we're all different the way that we perceive different situations going on in our lives. Individual temperament is another thing. So again, we're all born with we all have like an inborn temperament. And it's really interesting because you kind of notice it when somebody is a baby. So if any of you have any children, or if you've ever been around small children, and then as you watch them grow, it's really interesting how those inborn temperament characteristics that are present from birth still persist, sometimes even through adulthood. And I can say that because I can see that in my own children who are now adults, that pretty much the same temperament they had as babies is pretty much it. And that doesn't mean that like if you have a very like kind of a highly reactive, emotional, you fly off the handle easily type of temperament, it doesn't mean that you can never learn to modify that or to deal with it. Certainly, there are ways to learn to cope with your temperament. Or if you have a very easygoing temperament, maybe you need to like beef things up a little bit sometimes and maybe work a little harder or do something a little differently, and you're just so relaxed that you have a hard time getting motivated maybe to do something a little different. So there are ways that we can modify that. It's not that all is a loss, but it is very interesting how that kind of how that whole temperament works. So I just remember one of my boys, the one who is the more easygoing kind of temperament. When he was little, we didn't realize that he had trouble with his vision. So he really needed glasses probably for years, but never let on. He probably always cheated on those eye exams. But anyways, so we were taking a long 12-hour car trip, and we're always like, they're buckled up in the back of the two boys are buckled up in the car seats in the back and kind of look back every now and then. How you guys doing back there? Good, good. Everything's good. So everything's good. And then 2 seconds later, the little one starts throwing up. Oh, well, you really weren't good, but he said he was good. So anyways, and, again, we'd so clean him up and whatever and start on our way again. And then we look back, how you doing? Good. 2 seconds later, throwing up again. Okay, he really wasn't good, but his perception, he's just got one of those temperaments like, oh yeah, I'm fine, and he's really not fine. The other one's a complete opposite, and I just remember one night he was probably 4 or 5 years old, woke up screaming in the middle of the night, and I ran into his room and expected, I don't know what I expected, blood all over the place or something, but I expected something serious, and I ran in, and he kind of was crying because his nose was running because he was getting a cold. Okay, so that was kind of how he responded. It was, to me, a little bit of a over response, but that's kind of how his temperament always was, and it kind of still is, even as an adult. Just irritability a little bit more, just really kind of maybe a little bit more demanding, or just not very patient, and kind of reacting emotionally. So yeah, those are kind of two extremes, but and of course there can be anything in between as far as temperament. But the way that you are really does affect the way that we react when a stressful situation occurs. And maybe some of you can even think about your own situations, your own family, your friends, or yourself when you've had to respond in the past to different things that are stressful. Your social support is a huge mediator of the stress response, because not just support groups, but even just having a social support system, having friends, having family, reaching out to people, and being able to get what you need from people. So the person who gets a diagnosis of cancer and starts talking about it to people and saying, oh my gosh, I've got cancer, and what am I going to do? And then they get consolation from people, or they get ideas, and hey, my friend went through chemo and this really worked to decrease their nausea. Maybe you could try it. Just that whole aspect of connecting with people and sharing ideas and sharing your stress. Just kind of, you probably have noticed this already in yourself. When you are stressed, who do you turn to? You probably turn to other people who have been through similar things that you've been through. And I truly think that's why I do see so many really positive connections in nursing school, that you guys all know what you're going through, and you are just so close by the end because you've been through so much together, and only you really understand what it's like to go through school. And your family and friends might be really understanding and helpful and supportive, but they're not going through what you're going through. So that whole aspect of support and having a support group of somebody who is going through what you're going through. And even though there are individual, nobody, you can never say, I know exactly what you're going through, because nobody knows exactly what another human being is going through, because we truly are that different. Maybe we're going through the same situation, but there still are going to be differences in how we, because of the temperament and our past and our perception of the event and all that. But I hope you don't think I'm talking you out of the idea that social support is important, because it actually is. Even if we can't say, I know exactly what you're going through, you can at least say, this is what I'm going through, and I can hear and understand what you're going through, because you're kind of still going through the same thing, even with those differences. I really hope that makes sense. But truly, it is important to think about when people have stress and anxiety and they're going through different things, whether it's you're working in a mental health area, or if you're working in any area of nursing, the fact that a self-help group is so, so important. Um, Culturally, we do have to think about some differences, though. There are maybe some cultures that people just absolutely do not want to disclose to anybody else what they're thinking or feeling. They're very stoic, or they feel like they can only really communicate with other people in their family, close circle of friends, or their own cultural group. And they would really have a hard time sharing with other people that aren't in that cultural group. So we do have to really think about that. And also, not being from Wisconsin, I found out when I moved here that there are many people in this area that are of the German culture that don't really like support groups, because, again, that's something that just maybe if they come from more of a stoic farming background, feel like you have to take care of it yourself, or just talk maybe just to your own immediate family, but you don't share it with strangers. You don't share personal things like that with friends. It's just, very few people. And certainly you don't go to a professional, you don't go to a therapist or a counselor. There still could be some of that, persisting in different areas. So something else I do want to point out, that as far as support groups, on page 161, there's a little paragraph on that, and they do talk about that there are a lot of online support groups. I would just check those out yourself, though, before you recommend that to a patient, only because there are some support groups. I know for sure there are eating disorder support groups out there that are actually not very helpful, because what they do is they encourage people to stop eating, to get thinner, to lose weight, and to hide their symptoms from friends and family. So, we do have to watch and make sure, look at something, make sure that it actually is a valid support group where people are actually getting help from each other, rather than, encouraging each other in destructive types of behaviors. So yeah, when we're looking at support groups for mental health, I think we do have to be very, really kind of careful about that. But there are a lot of really good support groups out there. Alcoholics Anonymous would be an example, or Gamblers Anonymous, things like that. There's, cancer support groups. Some people love that, and some people just really don't, but they might like an online group because it's just a little bit more anonymous. So don't forget to recommend those to people, but do check them out first. Our spirituality and religious beliefs sometimes can be mediators of the stress response. I know that when we were talking to patients on 1K, that many times that if they do have some strong spiritual beliefs, that really can be very helpful in terms of the way that they manage their stress, and also just their outlook on life. And it can even prevent people from becoming suicidal if they have really strong spiritual and religious beliefs, and if they find those beliefs to be supportive and and valuable that way. So we do have to we do have to think about that, and it's really good to encourage people to work on their spiritual well-being, that it really does help people to cope and deal with issues. There's, again, a really nice paragraph on that in your book on page 162. So nursing management of the stress responses. So we've talked a little bit about stress, and I'm sure that you know what stress is. And sometimes it's good to measure stress. And you might think, well, why? Because this social readjustment rating scale, this Holmes and Ray scale, is actually very valuable because if you actually do it on yourself and just see what you come up with. I actually did this on myself when I moved here. I moved about almost 24 years ago here to Wisconsin from Rochester, New York, which is where I basically grew up. And I had a job there that I loved, and my family was all there. I went to school there. My friends were all there. Everything comfortable and familiar was in Rochester. And then I had to move to Sheboygan. And that was a big stress. And I had been only married a couple years, and we were selling a house. We were building a house. And I had 2 little kids and a toddler and an infant when we moved here. And lots of stressors. I started a new job at LTC in January. And so I kind of went through, and I was getting a lot of migraines. I was getting a lot of migraine headaches, especially during those initial few months of adjusting to a whole new place, 700 miles from my home. And I kind of went through and I just looked and kind of added up my stressors. I think I was somewhere over 300. And that's about where you are when you're probably going to get sick. And I didn't get physically sick. I didn't come down with anything, but I was getting about 2 migraines a week. So I think the thing that's valuable in this is that it doesn't, it's not going to necessarily predict what exactly is going to happen to somebody, but it certainly is a good predictor to say if your stress level is that high, even if some of the things are good stresses, like having 2 children and having, building a house, that's all very good stuff. Starting a new job, that's great stuff. But it's the fact that it's all new and different, and it is still something that your body and your mind has to adjust to. So if you look at this and you realize that your stress level is that high, it's probably good to then take some steps to try to modulate your stress level a little bit, perhaps do something different to decrease your stress level. I'll talk about that in a little bit. There's a little case study that's coming up where, we're going to think about different coping styles and different things that we can do to cope. So it's just very predictive as far as that you're probably going to have some type of response to stress when you take that Holmes and Ray scale. And it just really looks at positive and negative stressful events over a 1-year period. So it's on page, let's see, I think it's on page 163. And it starts on page 163 and ends on page 164. So anyways, just kind of good to look at some of those things, and perhaps even with some of our patients, we might even want to use scales like this. Okay, there's also on page 165 a perceived stress scale, and there's 10 items, and it's basically asking in the last month, how often have you, but whatever. Never, almost never, sometimes, fairly often. Again, some of these rating scales can be very, very helpful for patients just to try to really pin down exactly what their feelings are and where they're kind of coming from. So lots of different ways to manage stress. There's relaxation techniques, deep breathing exercises. Biofeedback is something that usually people will go to a doctor's office to learn the technique. They hook you up to a machine and you practice different ways to decrease your anxiety level. And pretty soon you are learning to decrease your own pulse, your respirations, and kind of your bodily reaction to stress and anxiety. And eventually the goal is to do those things without being hooked up to the machine. So you don't need to be hooked up to the machine constantly to to really benefit from biofeedback, but it just kind of shows you how you can do it. And then by being hooked up to the machine, you can visually see, your pulse and your respirations being measured, and things are lowering. But so that is a good technique, and usually it would be perhaps a nurse practitioner, somebody who is a higher level practicing nurse might do something like that. A psychologist also would be, a therapist would also be somebody that you would learn biofeedback from. Deep breathing, you can definitely teach your patients deep breathing. So whether they're on the mental health unit or they're in pre-op and they're really worried about their operation they're going to have tomorrow morning, and they're really kind of panicking, we can always, there's some of these things that just a regular staff nurse can be leading their patient through to really help them. And as a student, it would be great if you could remember some of these and just maybe put a little sticky note or something, a bright little pink sticky note or something on there, just to kind of flag some of these pages, because you will definitely benefit from teaching these things to your patient when you do your clinical rotation in the fall. So deep breathing is wonderful, but some of these things are helpful for some patients and maybe not for others. I know that there's been a few patients who just did not like the deep breathing exercises. So if somebody is like that, they're very helpful for most people, but if it's not helping your patient, there's other things. So guided imagery, progressive relaxation, meditation, and mindfulness. Mindfulness just seems to be huge lately. Every time I turn around, I see some advertisement for a mindfulness session in order to learn that technique. It just seems to really be kind of taking off. Physical exercise is certainly something that we can recommend to patients. And even if they can't afford to join a gym, they're not, they can't afford to go to the Y, or they can't afford a gym, they can't afford an expensive home gym or equipment. You don't have to have anything like that, in order to exercise, right? You can just walk. That would be a great exercise. You can take a couple of tomato soup cans and just do some, do some weightlifting. There's lots of things that you can do exercise, for exercise that really doesn't cost anything. So I know that that's a really big barrier for some of our patients, but that is absolutely huge as far as promoting overall health and relaxation. Cognitive reframing, so really teaching a patient to look at something in a different way. So it's usually looking at something negative in a more positive way. So if somebody gets fired from their job, you can teach them to say, well, I got fired from my job. That seems like it's a negative thing, but maybe now I can really hone my skills and look for another job that I will like even better than my first job. So it's just putting a positive spin on things rather than just wallowing in the negative aspect. Journaling, again, I'm going to say, just with a little bit of a hesitation, some patients love journaling and find it really, really helpful, and other patients really do not like journaling. So they used to promote journaling on 1K quite often, and they used to actually give out journals and kind of promote it, with just about everybody. But they don't really do that so much anymore, and I'm not really sure why, but I do know that some patients really enjoy it, and some patients find that it just makes them angrier, like they're dwelling on their, they write down all their thoughts and feelings and their anger and their hurt and whatever, and then they look at it and they reread it and they keep reading it over and over again, and it makes them actually feel worse. So that's the person that journaling we would not want to recommend, would not be very helpful. But the person who can journal something and then close the journal, put it away, and feel a sense of relief, that would be the person that journaling would work very well for. Humor is an outstanding technique. And again, if you, I did the separate little recording on the defense mechanisms. And so humor is actually an outstanding mechanism to use because it just helps with um, just releasing endorphins, which again helps your kind of like your happy brain chemicals. You feel better physically. It just helps your whole mood, frame of mind, if you look at something with like a little humorous twist. So I do think that it's very helpful for you guys in going through school to use humor. And I do notice some students using humor at times. And as long as it's appropriate, I think humor is a great thing. And it's something that I think that we can think about in clinical a little bit more, and we can talk about how you use humor maybe a little bit more appropriately. It's not always the best thing to use in different situations in a nursing clinical setting, but for yourself, as far as a way to cope, watching a funny movie, reading something funny, just reading the comic strips can be just really helpful as far as using our coping skills. So these are all just some ideas, and again, some things might work better for other people. Some people just really don't, maybe they don't like humor, they don't have a sense of humor, they don't like exercise, or they don't like mindfulness. So there's lots of things that we have to pick from. It's a matter of finding the thing that really resonates with your patient. So there's 4 coping styles that we can think about too. So this is a really great thing to think about when we're working with patients in the clinical setting. So the 4 coping styles are health-sustaining habits, life satisfactions, social supports, and effective and healthy responses to stress. So when we think about health-sustaining habits, we can think about things like your diet, so having a good, healthy diet, and taking medications that you're supposed to, so being compliant with your medications, whether they're medications for a physical problem or for a mental illness, relaxation, and really pacing your energy. So not, pulling all-nighters and then getting 0 sleep and then maybe sleeping 24 hours. It's just really pacing your energy and working hard, but also relaxing hard too. That's very important to do that. Life satisfaction, so work, family, hobbies, spirituality, humor, the arts, nature, all those things can be really helpful. It's really a great thing to even just take a walk in a park. Just look at some beautiful aspect of nature and just appreciate it and enjoy it. Go to an area that's beautiful, and it really does help and increase your mood. So life satisfaction is very important. Social supports, again, people that surround yourself with people that are positive, that are life affirming. Sometimes there are people that may be draining or just really difficult people to be around, or maybe that are critical of you, and maybe those people are people that you don't want to spend as much time with. So it really is important to think about your social supports, and then just having effective, healthy responses to stress, because we all experience stress, but it really truly matters how you respond. So, little case study. Maggie, a college student, is experiencing stress in her life. I don't know what to do, she says. I mean, this is supposed to be this awesome, exciting time in my life. Finally going to college. I love college. I love being a student. But honestly, trying to juggle my schoolwork, job responsibilities, and single parenting is starting to make me feel pulled in a million directions at once. So maybe some of you are feeling like that. And whether you're a parent or not a parent, there still might be several different things that you really enjoy in your life. And then when you're in school, it can be really difficult to feel like you have some kind of a balance. So I would bet that many of you can relate to this little case study. So Maggie, our college student, is aware that she needs help. On the 3 afternoons a week before she starts classes, she has lunch with her 2-year-old daughter on campus. then goes to a yoga class right on campus that also provides childcare. After yoga, her sister picks up her daughter, and then Maggie goes on to class. So she has a little bit of support from friends and from family member. So a family member is taking care of her daughter, which kind of relieves her of some of that responsibility. So I'm trying, Maggie says. It's still not easy, and I still feel a bit overloaded, but this is at least making some difference. It's a start, a step. So very important to think about when we're working with patients and even thinking about yourselves, just pacing yourself and taking small steps to change is very important. It's really difficult to change your whole life like instantaneously. It's something that really needs constant work, and you really have to sometimes carve out time for yourself. Yeah, it can be really difficult being a student. So, but it's a great thing to be a student. So I'm certainly wanting to put that positive spin out there because you're studying to be a nurse and you're all going to be wonderful nurses and you're going to be having a great career. So continuing on with the case study, as Maggie continues to develop ways to manage stress in her life, she works at developing these 4 coping styles that we talked about as much as possible. Already, the yoga class and lunch with her daughter has become an effective and healthy response to stress that is also health sustaining. In the area of social support, she relies not just on her sister, but on a group of single parent students that she finds on campus who meet to share things that work for them. So it is great to share with people different ideas and ways that they manage stress, because perhaps somebody does something that you hadn't thought of and that might be very helpful for you. So that whole aspect of connecting and sharing is really important. Okay, chapter 15, anxiety and obsessive compulsive disorders. So anxiety. So you might think, okay, really, what is anxiety? We have to, I guess, come up with at least a little bit of a definition of it. So it's apprehension, uneasiness, uncertainty, or dread from a real or a perceived threat. So again, perceived is kind of a good word to think about here because the threat might be real or it might be just something that is perceived. So just an example, if you think about the anxiety of perhaps starting something new, starting a new job or starting a new class, and you don't know anybody yet. You don't know your instructor, you don't know other students in the class. And so you might have some anxiety and think, oh, what if nobody likes me? What if I'm not accepted? So it might be your own perception of what's going on rather than the real situation. So we always kind of have to think about that perception part of it. So fear is a reaction to a specific danger. So you're driving along and your car stalls right in the middle of a railroad tracks, and then you look to your left and you see a train coming. Okay, that's fear. That's, oh my goodness, I better get out of my car right now because my car is stalled and it's not moving and there's a train coming. So that's fear. You're responding to something very specific. So normal anxiety is really necessary for survival. If we didn't have it, then we wouldn't live very well or very long. So just think about your book kind of talks about way back and hunting the mastodon and all kinds of stuff. But just think about if we were so relaxed and didn't have any anxiety at all, you wouldn't even look both ways before you cross the street. You would just cross the street and just not even really be thinking about anything, and perhaps you'd get hit by a car. So normal anxiety is necessary for survival. We all have it. We all have varying degrees of anxiety. And again, we may have different levels of fear also related to different specific kind of situations. The one thing I do want to say about anxiety, though, is many times when we're working with patients, we do kind of look for, like, what are they anxious about? What is the situation that is causing their anxiety? And honestly, there are times when some people truly have no idea what's making them anxious. They simply have a an imbalance in their neurotransmitters, and they have that inborn temperament that maybe perhaps makes them a little bit more on edge or a little bit more emotional, and they can't always pinpoint what is making them anxious. It can be just a feeling that overcomes somebody, such as when people have panic disorder. They are not necessarily panicking about a specific thing. There may or may not be specific triggers. Sometimes the feeling is just there. Some people are lucky and they don't have really high anxiety levels, and other people are just way high on that continuum, and that's just a part of their daily life. So, again, just some kind of things to think about. So, levels of anxiety. For sure, you should really know the difference between mild, moderate, severe, and panic. Definitely, that will be incorporated into some test questions. So, mild anxiety is actually good because, again, without it, we'd get hit by cars because we would just cross the street. We wouldn't even care to look both ways. So, mild anxiety is good, and it helps us to solve everyday problems. It helps us to grasp more information effectively. Um, if you didn't have any anxiety at all, like just for example, going through school, you would just sit in class or you would just like sit and listen to these lectures and just think, well, whatever, and you wouldn't maybe really take note. But if I say something like, oh, you better know this, might be on the test, or these concepts I'm for sure going to test you on, then that little bit of anxiety kind of jumps in and you're like, oh, okay, I better write this down. I better pay attention to this. I'll make note of this. And that's anxiety, but that's the good mild anxiety that we really need in order to kind of function more effectively. So, you are learning and grasping things when you have mild anxiety, and your problem solving usually becomes really pretty effective. So you might have some little bit of discomfort, though. You might feel a little bit restless or a little bit irritable. It kind of depends on the situation. Nail biting, there might be some tension relieving behaviors like nail biting, finger or foot tapping, fidgeting, things like that. So that's mild anxiety. Moderate anxiety is when people start to have selective inattention. So in mild anxiety, you're paying attention, you're heightened awareness, you're kind of like, oh, wait, I better pay attention to that. But with moderate, you're kind of missing some information. So you're catching some things and other things you're completely missing. So if you have moderate anxiety and you're sitting in a classroom, perhaps maybe the instructor is going to tell you about an assignment coming up and they're going to mention some very important aspect to that assignment, but you kind of missed that. You kind of get the due date, but you kind of missed some important aspect of that assignment. So with moderate, you've got selective inattention. You miss sometimes very key pieces of information. You're not thinking as clearly as you would if you have mild anxiety. So your thinking is hampered, your problem solving is really not optimal. You maybe only can think of one or two things, or maybe just one way to react, or you might think of one answer, but you're not thinking more broadly. You're not really thinking of the whole realm of possibilities. So, yeah, so problem solving is just not very optimal, and your sympathetic nervous system symptoms really begin. So some of those symptoms might be like your heart might start pounding, increased pulse, respiratory rate. You might start to sweat a little bit, and maybe a little bit of like stomach ache or something, headache, urinary urgency. So that having to go, run to the bathroom, a little bit of voice tremors, shaking, things like that. So it's actually mild anxiety would be a better level of anxiety to have, even like when you're taking an exam. So you want some anxiety because you want to pay attention and read the questions and make sure you answer the question correctly, answer what the question is asking. But if you have moderate anxiety, you're probably skimming over some words, or you're just not even perhaps getting what the question is asking you, and you're getting some of those physical symptoms too. So it's better, like on a test day, to try to get your anxiety down to the to the mild level rather than the moderate level. I know, easier said than done, but I do have in the in the learning plan, under learning plan 2, there is a YouTube video. It's called Weightless, and it's music. And basically, I read an article where if you listen to this, it can decrease your anxiety by about 65%, which is pretty amazing. I actually tried it in class. I just had it playing in the classroom this past semester, and just had it playing before class, and I didn't say a word. I didn't say it was anxiety reducing music or anything. And a couple of students came in early and they were kind of listening to it, and one student just actually said, "Oh, you know what? That's really relaxing. I feel so relaxed." It was great because I hadn't put the idea in their head that that's anxiety reducing music. So actually it was kind of cool. So it's Weightless by, I think it's Marconi Union. So that might be something worthwhile to listen to before an exam to try to reduce your anxiety level. In addition to, again, some of those things that we talked about before as far as mindfulness and deep breathing, guided imagery, progressive relaxation, all those techniques are things that you can actually kind of learn to do on yourself. But anyways, I digress a little bit. But anyways, okay, now severe anxiety. So severe and panic are actually pretty close, but there are some definite differences that you will need to know to answer test questions correctly. So when you have severe anxiety, your perceptual field is greatly reduced. So that means that you are not paying attention to everything going on around you, but you are paying attention to some things a little bit. So it's not like you're completely absorbed in your anxiety like you are in a panic, but you're not as aware of things going on around you like you would be if you had mild or moderate. Okay, so your perceptual field is greatly reduced. You have difficulty concentrating then on the environment. So you're not always aware of what's going on around you. You're, again, really missing information way more than you would in moderate. So you're really not getting a whole lot of information at all here, just a little bit perhaps. You may act confused and have kind of automatic behaviors, and the somatic symptoms really, really increase. Headache, nausea, dizziness, insomnia, all those things, trembling, pounding heart, hyperventilation, sense of impending doom or dread. So those are all those terrible feelings that really come with severe anxiety. When people have this severe level of anxiety, many times they just need you to tell them like step-by-step directions on what to do because they're so overwhelmed and they're not, again, their perceptual field is so reduced, they're not always aware of everything. You know, they're aware of a little bit going on around them, but not much. And actually, if you kind of get right in front of their face and kind of help them to focus, you can tell them step by step, one step at a time, of course, directions on how to do something. They may be so overwhelmed that they can't even eat. So you have to tell them to pick up their fork and stab their potato and put it into their mouth. You know, it's literally sometimes that step by step when somebody has severe levels of anxiety. Panic. They have just markedly disturbed behavior. They could be running, shouting, screaming, pacing. It is really purposeless behavior. It's not purposeful. Okay, so they also their perceptual field is they are completely absorbed in themselves, and sometimes they really truly are not perceiving anything going on around them. They might be very impulsive. They may be unable to process reality. They don't know what's going on around them. So that is something that's really difficult. Anybody can have a panic attack. Sometimes there is something called panic disorder where people just have panic attacks that just come out of the blue. So that's one type of panic diagnosis. You can also have a panic reaction, and we'll talk about this again as this learning plan goes on. If you have a phobia, say if you're phobic of cats and all of a sudden a cat walks in front of you, you could have a panic attack or a snake or a spider or anything that is you have a phobia about. And if you are confronted with that object and you can't get away, you may end up having a panic attack. So you can panic in many different ways. Something really stressful happens and you can have a panic response. So it can be part of an illness, or it can be an illness all by itself, or just a symptom that perhaps comes when a traumatic event is happening. So, but people who are in a panic really need somebody with them. You have to stay with them at all times. You should never leave anybody alone if they're having a panic attack. They will start to focus eventually. Usually they don't last more than 10 minutes. But if you're having a panic attack, 10 minutes probably seems like the longest 10 minutes of your life, right? So it seems long to them, but it's truly about 10 minutes. And the important thing is to stay with a person and to help them through it. They really don't need to be alone during that time, and that just makes things much worse. But we also don't want to overstimulate them either. So probably one of the most important things that we can ever do when somebody's anxiety level is high, either in the moderate, severe, or panic, is to decrease stimulation. So, yep, you should write that down. If we decrease the level of stimulation around them, then they can start to calm down. The environment won't be, at least the environment, it's not necessarily that they're going to instantly calm down, but the environment won't be contributing to their level of anxiety and making it worse. So that is a really important thing to remember when you're working with people that have anxiety issues. Just the other thing I want to say quick about panic is that if anybody is in a panic state, they truly are at risk for injury because they are not perceiving anything going on around them. They could be, again, running, shouting, screaming. They're not paying attention. They could run into the street and just run into traffic and not even be aware that there's cars around them. So they truly are at risk for injury. So defenses against anxiety, again, I have a whole I just kind of pulled that out separately. So I did that whole recording about the defenses, and so I'm hoping that you've maybe listened to that already. But we have to think about when we're going through all of the different types. I guess I pulled it out separately because there are so many different times when we're going to kind of reference it, and then instead of going through the whole learning plan 2, it's just easy to kind of maybe go through that again a little bit, because I will ask you, I know, in a discussion question for the eating disorders, like what defense mechanisms do people use that have eating disorders? And we'll talk about those as we go through some of the other illnesses too, just what defenses people are using. They really are very interesting. We all use them. They protect us from anxiety, maintain our self-image, and again, they can be healthy or unhealthy. Audience response question. Anita, 34, is shopping with her 5-year-old daughter in a large, busy urban mall when she suddenly realizes the child is missing. Which level of anxiety would likely result? Mild, moderate, severe, or panic? So I'm hoping you said panic, because if you are all of a sudden your 5-year-old is there and they're not there 1 second later, that would be pretty stressful. I think that would send any parent into a panic level of anxiety. So that could be an example of just a type of situation that can provoke a panic type of response. What behaviors might Anita be exhibiting that would indicate panic level anxiety? Seeing and grasping information efficiently and quickly to make problem solving more effective. Voice tremors, perspiration, and headache. Dazed, confused with automatic behaviors aimed at reducing anxiety, or running, shouting, and screaming. So I'm hoping that you picked D, running, shouting, and screaming. And actually the other 3, A is really mild anxiety, B is moderate, and C would be severe. Okay. Back to the case study. Anita finds her little girl, Hillary, close by, looking at kittens in a pet supply store window, and is obviously relieved. I feel sick to my core, she says. I thought for sure my panic attacks were coming back for good. Anita has in the past frequently experienced sudden feelings of impending doom in which I feel like I am losing my mind or having a heart attack. They started when I was a teenager. So this case example is somebody who's having a panic attack promoted by a very scary situation, but also that she has a history. So not everyone that has a panic attack in a difficult situation always has a history of having a panic disorder. So I just wanted to point that out. So another thing to think about is separation anxiety disorder. So we're looking at now the clinical picture of some specific anxiety disorders. So when we think about the clinical picture, we're going to be looking at different signs and symptoms of many different disorders. So on page 273, they talk about the clinical picture of very specific signs and symptoms according to the American Psychiatric Association. So anxiety disorders include things like separation anxiety, specific phobias, social anxiety, panic disorder, agoraphobia, generalized anxiety disorder, obsessive compulsive, body dysmorphic, hoarding, trichotillomania, which is hair pulling disorders, excoriation or skin picking disorders, lots of different types of things that we're going to be looking at, and you're really looking at some of the specific signs and symptoms. So separation anxiety, you probably know something about separation anxiety because we really see all children go through this. So developmentally, it is really pretty appropriate. Begins somewhere around 8 months of age, peaks at about 18 months, and it starts to decline after that. However, some kids do persist in having separation anxiety, especially when they are perhaps dropped off at daycare or they start school, especially if they're going to a new school or starting a new grade. Sometimes those separation anxiety symptoms can kind of keep reappearing. But people that have the actual disorder, so we're really talking about developmentally, it's really pretty normal to have some separation, but when people develop an actual disorder, they are developing developmentally inappropriate levels of concern over being away from a significant other. So what they're really talking about is that normal activities are disrupted and that they have symptoms, physical symptoms sometimes, sleep disruption, nightmares, gastrointestinal disturbances, headaches. So it's really more of an adult version of separation anxiety. So people may end up being just really very kind of clingy and needy. They're afraid that significant people in their life, something really bad's going to happen to them. And so that can really significantly impact their relationships with other people. So other characteristics that your book talks about includes avoidance of harm. So really having maybe a very safe lifestyle, like never taking any kind of risk. So harm avoidance, worry, shyness, uncertainty, being really easily fatigued, and having kind of a lack of self-direction. So those are all signs and symptoms of this type of disorder. So many times people really do fear that something terrible is going to happen, and to some significant people in their life, they're going to be left alone. They're not going to know what to do. So it actually there's some similarities between this and also when we get to the personality disorders in Learning Plan 4, you're going to be learning about dependent personality disorder. So to me, some of those symptoms really kind of go hand in hand. Okay, so that's separation anxiety disorder. Panic disorder. So people actually have full-blown panic attacks, and sometimes these attacks really just come right out of nowhere. So it could even, they come out of the blue. They can sometimes even happen. They can wake people up from sleep. So really very, very uncomfortable for people to experience a panic attack. So really the key symptom that we're looking at is that extreme apprehension. Usually they feel like they have a feeling of impending doom, like something just horrible is going to happen. Again, their perceptual field is really gone. They just are really focused on themselves and what's going on inside, internally. They misinterpret reality if they even perceive anything of what's going on around them. They feel like they're losing their mind. Sometimes they feel like they're having a heart attack. Actually, sometimes we've had a few instances in clinical where patients have complained of having chest pain, and it's been actually part of either a panic or an anxiety attack. So, all right. Agoraphobia. So, excessive anxiety or fear about being in places or situations from which escape might be difficult or embarrassing. So, people that have agoraphobia usually don't go out of their house. It can be so severe that the therapist has to come to them, that they can't even leave their house to go to a therapy appointment. So very, very difficult for people that have this because they're constantly afraid of what's going to happen when they're in the outside. It's just too much for them. So they really feel like, what if I get panicky and do something that's really going to embarrass myself, and they just really kind of mentally talk themselves out of being able to leave their house. So I think the actual translation of agoraphobia is fear of the marketplace, so fear of being out in public. So when people have agoraphobia, they usually develop some kind of avoidance behaviors. And again, very, very limiting on their lifestyle. So therapy is very, very helpful for people that have this or any anxiety disorder. Specific phobias. So usually if somebody has a specific phobia, they're really quite fearful and have physical and emotional symptoms at the same time when they are confronted with that phobic object. On page 275, there's a little purple table, and it's called Clinical Names for Common Phobias. I really don't care that you memorize. Don't go, spending time memorizing different types of phobias. I'm certainly not going to test you on if you know what glossophobia is versus hydrophobia. So anyways, glossophobia is fear of talking. That's interesting. And hydrophobia is fear of water. Anyways, you don't need to know the terms, but just to know that there are a lot of different things that people can have phobias about. Heights, open spaces, electrical storms, closed spaces, claustrophobia, blood, water, being alone, germs, dirt, darkness, stranger animals, actually some other ones that aren't listed in your book that I have heard students mention. Fear of clowns, so or mascots, like at the ballpark or at a football game or something. Sometimes there's a mascot, and people can be phobic about a clown or a mascot. I have heard of people being phobic about cotton, feathers. I'm trying to think of some other unusual ones. Anyways, maybe you can think of a couple of unusual specific phobias. Snakes, spiders, those are kind of common ones that people might have. So again, people are usually doing avoidance behaviors. Sometimes there are, with some of those specific phobias, you really can work to avoid having being confronted with that thing that you're phobic about, so that you don't have the anxiety. But there might be some things that you can't avoid. You can actually have phobias about like riding in elevators or driving across a bridge, things like that. And usually when you are confronted with the thing that you're phobic about, usually you have a panic attack. So again, panic can be it can be a diagnosis in and of itself, just having these panic attacks that just happen, or it can be a result of really almost any of these other anxiety disorders that we have. So certainly you can have a panic attack when you are confronted with a specific phobia. So some people have perhaps Oh, let's see. What would be one that they could easily avoid? Well, water. I mean, if you're thinking about like a body of water, certainly we can't avoid water completely because we do need it to drink and to bathe, things like that. But if people are phobic about like large bodies of water, like being afraid of drowning and things like that, perhaps they will never set foot in a pool, perhaps they will never go to a lake, and you could probably live your life pretty okay and avoid those things and never have that panic reaction. But if you work on the 35th floor of a high-rise building and you have a phobia about elevators, it might be kind of difficult to take the steps for 35 flights. So you might have to take an elevator. And in that case, certainly there are ways that therapists can help people, or advanced practice nurses can help people to learn to deal with lowering their anxiety levels so that little by little they can finally get over their phobia. So it is possible for people to actually get over their phobias. So they really are kind of interesting because they are so, they're so powerful. Sometimes our emotions and feelings are so very powerful, and it can be just stimulated by, again, the sight of a spider or a snake crawling through the grass, not even a poisonous snake, but maybe just a little garter snake. Some people might have a panic reaction. So it really is kind of an interesting phenomenon. So this so this is just kind of a little cartoon just showing some specific phobias. There might be some people might have phobias about bats, again, snakes, spiders, flying on airplanes, lightning, any of those things. So it's usually a very specific object or type of situation that people want to avoid. So, social anxiety disorder. So that's something that people can experience they have severe anxiety usually or fear provoked by exposure to a social or a performance situation that will be evaluated negatively by others, or at least they think it will be evaluated negatively by others. So sometimes even just like getting up on stage or just talking in front of a class, some people really can't even stand up and talk in class, much less give a speech to a group of people. So that would just create way too much anxiety. Or even there are people that have social anxiety, not even in performance situations, but even on social, like one-on-one situations where like going on a date or something like that might just provoke a lot of fear. The other situation that comes up a lot, like in clinical, is patients that have social anxiety have a really hard time going to group therapy. And many times the doctors really want them to go to group, and it's good for them to go because they will learn so much coping skills and things, and it's really a good experience for them. But boy, it's really hard to get them there if they have social anxiety. So many times they will prefer to talk to you, the student, or perhaps talk to the nurse or talk to the therapist, but just not to attend group. It really is a very difficult situation for them. Um, okay, so social anxiety. So again, it can really hamper somebody's lifestyle quite a bit, very possibly. And generalized anxiety disorder is just another name of a specific illness. So there really is something called generalized anxiety disorder. And that person is going to experience excessive worry that lasts for months. And usually it's worry like all day long, it just doesn't stop and for months at a time. Because just to differentiate it, you might be thinking, well, I worry about things and why I don't have this diagnosis. And perhaps we all worry about things. So it doesn't mean, again, that think about that continuum. It doesn't mean you have a specific diagnosis. It just could mean that perhaps you have some stressors going on and you're a little bit more worried than usual, but then you're probably going to go back to being the way you were. So people that have this disorder, they have this excessive worry that lasts for months and months and months. And many times they just are thinking about the worst case scenario. So they can't even enjoy life sometimes because they're always worried about what if. So, for example, kids get a BB gun for Christmas and they're all happy and excited about it. And then grandma comes over and says, "Oh my gosh, I know somebody that got killed when they, because of a BB gun." It's like, oh, that's probably either didn't happen or would be so rare. But that would be something that the person with anxiety would worry about. They would worry about the worst case scenario. Oh, don't let them ride a bike because they're going to fall off their bike and they're going to get a head injury. Well, you can't avoid everything in life, right? So, but that person with this generalized anxiety disorder, they're just plagued by constant thoughts and fears and images, and they just can't get those out of their head. Of course, there is help, so I'm not making it sound like it's all hopeless, but it really is something that people really very much struggle with. So, little cartoon of social phobia. So, it really is more than just shyness, but sometimes people might be described as being shy if they have social phobia. And yes, they can learn to interact with other people a little bit more comfortably. But again, it might be needing to be taken in small steps. Maybe just first start with interacting with one person and then maybe, build the group a little bit larger until they're more comfortable, but definitely done in stages. So just a little cartoon about some anxiety symptoms. These symptoms can occur in any of the disorders that we talked about. Having that sense of dread, feeling shaky, feeling faint even. Some people get wobbly legs, like they can't stand or can't walk very effectively. Heart starts beating rapidly. Sometimes people experience like a little choking kind of a feeling. May even feel like nauseous. So just a little cartoon about some anxiety symptoms, maybe to kind of help you remember a little bit. So, other anxiety disorders, we always have to think about, is this anxiety from a substance? And I'm not only talking about illicit substances, but also we have to think about medications. So, we as the nurse need to really be in tuned to what's going on with our patients. If they start on a new medication and then all of a sudden they're having anxiety symptoms, it's very possible that they're having a side effect. So when you look up your medications, you're going to notice many medications, especially medical meds, and even some of the psychiatric meds that we give, have as a side effect anxiety. So that is something we really have to take very seriously, that it could possibly be something that is a medication that's prescribed. So we always think about illicit substances, perhaps, also can cause anxiety, and that's absolutely true. But don't forget about the things that we prescribe and encourage people to take their meds when, in fact, that sometimes it's possible that they're causing their anxiety symptoms. So other substances certainly could be illicit substances. A stimulant like cocaine is certainly going to cause anxiety. LSD can cause anxiety. Marijuana, alcohol. People take alcohol as a sedative to kind of sometimes calm them down, but honestly, it can actually increase anxiety. So we do have to look at substance-induced anxiety. And then the other thing that's super important for us as nurses, again, we're not doctors, we're not diagnosing people, but it certainly is good for us to take a look at people's lab values or lack of lab values and say, this person has anxiety symptoms, and kind of question whether or not perhaps a thyroid level should be checked. So sometimes people have anxiety when they have hyperthyroid issues. And if they're hypothyroid, they may have symptoms that look very much like depression. So hold that thought. That'll be learning plan 3, will be the mood disorders. So we do have to think about anxiety due to an actual medical condition. Cardiac conditions can cause anxiety. Respiratory conditions, certainly. If you think about how anxious you feel if you're short of breath, those two just really go hand in hand. Heart conditions. So we really do have to, as nurses, think about the impact that a medical diagnosis can have on somebody's anxiety level. Case study. Anita recalls the height of her struggles with panic disorder. My attacks would come out of the blue, usually when I had already been super depressed for a while. They were so bad that I started being more afraid of the panic attack itself, and sometimes I would just stay home from stuff I usually really liked, like the high school football games and even slumber or birthday parties, because I was afraid of having an attack in front of everybody. So that's very, very typical that sometimes people tend to kind of avoid social situations and kind of seclude themselves and just stay by themselves because they're just more afraid of the panic attack happening, than they are of the actual attack. It's that fear of the fear. And so that is really a very, very typical thing that happens. Okay, obsessive compulsive disorders. Very interesting disorders, but really very distressing to the person. So I do have some videos, some YouTube videos, and one of those, I think I have either one or two videos, I don't remember offhand, but I think one of them is on Howard, I couldn't think of his name, Howie Mandel. So one of the videos is on him for sure, and definitely interesting to watch because how deeply this OCD has affected his life, and really think about when you're watching that video how it's affected his relationship with his wife, with his children, with coworkers and people that that he comes in contact with. Yeah, it's a pretty interesting video. So anyways, these people really are, we have to remember all of these anxiety disorders, people truly are suffering. So when you have obsessions, that's the thoughts, the impulses, or the images that persist and recur so that they cannot be dismissed from the mind. So you can't stop thinking about it. And sometimes the thoughts are things like germs or dirt, things are not clean. That's usually a very common one. Besides dirt and germs and things being unclean, another kind of obsessive thought that sometimes people have just as like a general category would be like safety. Like things aren't safe, like they think they hit something while they were driving, and so they have to stop their car and turn around and go back and see if they think they hit a person, and a person is lying in the road, but they didn't actually hit anything. So just that constant like checking and rechecking. Or another one, a really good example of like the safety issue would be a student actually told me this, that they knew somebody that had an obsession about, they always thought that their curling iron was still turned on and their house was going to burn down. So this person would unplug their curling iron after did their hair, and they would start driving to work, and then they would stop and they would have to turn around and go back home because they weren't sure if they really unplugged it, so they'd have to go back and check, and then okay, it's unplugged, all's good. They'd start back to work again in their car, and then they would, was it really unplugged, or was it still hot? Could it burn something? Is the house going to be burned down when I get home from work? So they'd literally stop the car, turn back around, and go back home and check the curling iron. So, this would continue, and this person would be late for work, and they were at risk for losing their job. So this person ended up dealing with the situation by actually taking the curling iron with them in their car. So that's kind of a creative way to handle that. But not everybody is able to to cope with their obsessive thoughts in quite that manner. But I thought that was quite creative. Anyways, so that's the thought, and sometimes the thoughts are also like germs and dirt, safety, sexuality can also be kind of an obsessive thought that people have that is very distressing to them. And then the compulsions are the ritualistic behaviors that the person actually feels driven to perform in an attempt to reduce their anxiety. So that is a huge, huge, huge concept about obsessive compulsive disorders is that anything that they do, they're performing their rituals, has to do with it makes them feel better. But the other very important part of that is that they do not enjoy their compulsive behavior. So when you think about somebody, if somebody has an obsession about germs and dirt and things are unclean, then they're going to be hand washing. That would be the ritual that would kind of accompany that obsession. So they will be washing their hands continuously. And sometimes they wash their hands to the point where their hands look like raw beef. You know, they're red and cracked, and you have all kinds of skin integrity and infection potential issues going on there because they're just washing their hands so much. So the washing their hands makes them feel better temporarily because it reduces their anxiety, but they really don't enjoy washing their hands. They don't like having to do that. So again, the person that has that sense of safety, they may again keep driving back to check something in their house, or they're going to just check and recheck something again, or they're going to turn around driving because they think and search for the dead body that they think is laying in the road of, you know, the person that they hit that they didn't really hit. So they have this ritualistic behavior that makes them feel better, but again, they do not like doing it. So that's kind of important to think about. So there is a group of disorders that kind of are classified as obsessive compulsive types of disorders. So again, there's regular OCD, there's body dysmorphic disorder, hoarding, hair pulling and skin picking disorders, and there are other compulsive disorders. So some people compulsively eat, and again, so many of these disorders really are so closely related. People can, you know, drink compulsively, eat compulsively. So when we talk about the addiction disorders, kind of this will come to mind again. And when we're talking about the binge eating disorder, especially where people just overeat large amounts of food, but they don't purge, they tend to end up gaining just maybe tremendous amounts of weights. That is also a type of compulsive behavior. So there's lots of different gambling. There's all kinds of different compulsive disorders that we have. You can also think about people that maybe, are kind of it's compulsions and addictions actually truly go hand in hand. So yeah, we'll talk about that more when we get to the addictions. But anyways, body dysmorphic disorder is something very interesting because people usually focus on one aspect of their body, and that part of their body they just feel is not normal. It's they feel like it's disfigured, and they're always trying to do something to fix it. What do you know a celebrity? I wonder if anybody can think of a celebrity, if anybody kind of comes to mind. This person passed away a few years ago, but somebody who kept repeatedly getting surgeries to alter his appearance, many surgeries, and the appearance was tremendously altered from childhood, from the way this person looked from childhood all the way up to the point where he died. So I'm hoping that you're maybe thinking about Michael Jackson. Now, I can't diagnose Michael Jackson as having body dysmorphic disorder, but just as a nurse and in looking at some of his behaviors and some of his thoughts and feelings about his facial features especially, I'm probably pretty sure that he could have had this. Again, I can't diagnose him. That's really not right. But I would guess, just an educated guess, that he probably had this. He really seemed to dislike especially his nose, and so many surgeries to fix what he believed was an imperfection, which if you look at pictures, it's really interesting just to Google pictures of Michael Jackson from the time that he was little and he was just first starting his career all the way up to the point where he died, and just how tremendously different that he looked over the years. And he possibly did have some like skin coloration issues also another perhaps physical illness kind of going on there too. But it's very possible that's something that people who have the money to do that with body dysmorphic disorder do. They get multiple surgeries sometimes to correct things that they feel are imperfections, even though nobody else would look at them and say that they were, abnormal. We had a patient who had this years ago, and she would just look in the mirror and think her face was distorted. Her face was not like other faces. And if you looked at her, she just had a very very normal, very average looking face. So there was nothing wrong with the way she looked, but it was her perception. She looked in the mirror and saw something completely different from what we saw. Hoarding disorder. Boy, that's interesting. So I don't know if you're like me and you like to watch those shows about people that are hoarders. Very, very interesting how they develop that and how they save things and what strikes me when I watch it was, again, getting back to those defense mechanisms, how they can rationalize why they're saving a scrap of paper or a scrap of plastic that anybody else would throw in the garbage, but they will have a rationalization. So they really use that defense mechanism quite a bit. Hair pulling and skin picking, trichotillomania is kind of hair pulling, and I've seen people like pull out like large chunks of hair on their head, all of their eyebrows, their eyelashes. So it's not just the hair on their head; they actually can be picking their other facial hair too. And skin picking, I knew somebody that actually had a skin picking disorder, and she picked the skin on her face to the point where um, she was having to cover it with Band-Aids. It was very, very obvious that her skin was just in really terrible condition. And for a while, she kind of told everybody that it was a reaction to medication, that it was kind of a side effect, and that she was on antibiotics to try to clear things up. And later on, that person decided to really just kind of come forward with that they were just compulsively picking their skin, and to the point where their family would be distressed because they would be like locked in the bathroom using a razor and just picking at their skin, not only with their fingers but also different types of utensils, and very, very distressing to the family also to watch this happen. So it's not just like a little picking at some dry skin. It's quite a significant disorder. So again, people do things, the actions that people take with these types of disorders is always to reduce their anxiety level. All right, just a little cute cartoon. Did you see that TV program on OCD the other night? See it, I taped it and replayed it 367 times. So just a little humor. It's really not funny though to the people that are, and I'm certainly not meaning to poke fun at people that have this disorder, because they truly, truly suffer. But anyways, just a little kind of a light, little bit of a light approach. Anyways, audience response question. A patient complains of frustration with his impulse to use tissues to touch or grab anything and everything around me. I just feel clean and safe doing it that way, but sometimes if I don't have a tissue, I can barely stand to open a door. This patient appears to have which anxiety problem? Panic, generalized anxiety, post-traumatic stress, or obsessive compulsive? So I'm guessing that you all picked D, obsessive compulsive disorder. Okay, the nursing process, we are always going to be assessing their symptoms, assess all the signs and symptoms that they have. And we, again, always have to think of the physical symptoms of anxiety as well as the psychological symptoms. We always need to do a self-assessment when we are working with people with anxiety, because we might, as the nurse, tend to be a little bit frustrated. We're not feeling anxious, so what are they anxious about? Or this situation wouldn't make me anxious. Why are they anxious? And we might just be a little bit frustrated. And it really does take some patience, because the person who has extreme anxiety, severe or panic level, might be asking the same question over and over again. They're not grasping information. You might feel like you're repeating. You already told them that. Why aren't they getting it? So we really do have to understand the all of the impact of the symptoms that they have. So with that self-assessment, we have to have a little bit of empathy. And I do ask you in the discussion question for this learning plan to think about a time that you have felt anxious, because I would bet that everybody has had some anxiety at some point in their life. It's almost impossible to get through life without having any kind of situation that makes you anxious. And then it really is easier when you think about how you felt to have some empathy towards other people. So we always are going to look at assessment guidelines, look at the specific signs and symptoms for the specific disorders, come up with our nursing diagnosis, identify outcomes, and then we plan our care. And we're always going to be working on planning some really good interventions to help people with anxiety. Your book just has lots and lots of ideas about different types of things that that we can use to help people to manage their anxiety. So again, I kind of told you before to kind of put a pink sticky note or something where they talked about different types of ways to help people cope, because when people are having an anxiety attack, it's not the time to teach them. We want to teach them when they're in a calmer state, so that when they feel that anxiety coming on, they can use their coping skills and maybe even avoid having a full-blown panic attack, perhaps. So we always, again, want to encourage, we don't do the we can do we can check neurologic status, things like that. Again, we're not the physician. We're not ordering like neurologic tests or diagnostic tests. But if we feel that the anxiety perhaps has a medical basis, we can absolutely, as a nurse, advocate for the patient to make sure that they get a thorough physical workup. That is so, so important, because it may be a medical cause or a reaction to a medication. That would be a really easy fix, rather than thinking somebody has an anxiety disorder and then trying to do some other type of treatment, which perhaps isn't even warranted, because if they were just put on a different medication, their side effects would go away. So always making sure that we advocate that they get a thorough assessment. Determining the source of anxiety, if it's there. Again, sometimes the anxiety can be people just feel anxiety, perhaps not necessarily tied to a specific event. So it's good to assess for that, but don't always expect somebody to be able to tell you what they're feeling anxious about. We want to determine the current level of anxiety. We always, in clinical practice, ask people to rate their anxiety on a scale of 1 to 10. Matter of fact, we use rating scales for just about everything in the mental health field. So we can have people rate their anxiety, they can rate their pain, they can rate their depression, the strength of their suicidal ideation, and if people are hallucinating, we can have them rate on a scale of 1 to 10 how strong their hallucinations are. So beyond the pain scale, remember that that is something that's very important with assessment in mental health, is having people use that rating scale to determine their level of anxiety or other things that I just mentioned. We always want to assess for the potential for self-harm. Sometimes people become so anxious they just can't stand feeling like that. If they don't feel relief from their anxiety, they actually may feel suicidal, or they may engage in self-harm behaviors, cutting, burning, things like that, that makes them actually feel better too. And it's kind of a coping mechanism, but it's obviously not a healthy coping mechanism. But sometimes people actually feel a level of relief from their anxiety if they engage in self-harm. So we always want to be looking for that. We always do that complete psychosocial assessment and try to see if they have support systems, what coping mechanisms do they usually use, things like that, if they can identify any causes, and again, always do that self-assessment. So nursing diagnoses, sometimes anxiety is actually a nursing diagnosis. It's a medical diagnosis, but it's also a nursing diagnosis. So we want people to monitor their intensity of their anxiety, use reduction techniques, and to be able to maintain their role performance. So really the overall goal when we are coming up with these some of these diagnoses is that we want the person to be able to function and to live effectively and have effective relationships um, in spite of their anxiety level. So we really want them to be able to cope effectively. Ineffective coping is a huge diagnosis. So we want to identify those ineffective patterns, and we want to help the person to modify their behavior. Chronic low self-esteem. Sometimes people really beat themselves up when they have anxiety. They're just super, super hard on themselves, super critical. And so we want them to verbalize self-acceptance and have more confidence and feel better about themselves. Self-mutilation, again, sometimes people cut or burn, things like that, scratch themselves in order to feel better. So we really want them to practice self-restraint and use other more adaptive coping mechanisms. Planning. Usually patients don't require inpatient admission unless they are feeling suicidal or completely. If they're having constant panic attacks and they can't function, I have definitely seen people admitted for anxiety. But most of the time, we think about anxiety issues as you can deal with those on an outpatient basis. So we also want to think about community-based interventions. So if there are biofeedback, mindfulness sessions, yoga, anything that helps people to learn, positive ways to cope. We want to encourage their active participation to increase positive outcomes. So if we tell a patient what to do, like I might say, really you should be doing yoga. That would be so helpful. And maybe that person is like, they're nodding their head and saying, oh, yeah. But they have no interest in yoga. They don't like doing yoga. They don't know where to go to learn yoga. And so we might tell them this wonderful thing and they're not participating in planning that. They're not going to follow through. So really is important to get their active participation. But patients, again, if they're experiencing a severe or higher level of anxiety, they're not going to be able to participate in planning during the actual anxiety attack. So we really always want to try to do our planning and teaching and involving them when they're feeling in a calmer state. So implementation, again, the most important thing for when people are in, no matter what level of anxiety, if it's mild, moderate, severe, or panic, is to decrease stimulation. So take them to a calm, quiet area, and the last thing we want to do is to have them out at the nurse's station, if they're an inpatient. There's people coming and going, walking quickly, talking, people on the phone, talking loud, slamming the phone down, whatever. Anything that is going to increase their level of anxiety, that is super stimulating. We want to take them to a quiet environment. That's probably one of the first things that you want to think about when somebody is having that. So again, mild to moderate levels of anxiety. Things that we can do are to decrease that stimulation. We could possibly offer them a PRN. However, what we're doing lately in practice is trying to get people to do at least 1 or 2 anxiety relieving techniques first before they get a PRN medication. So it's not that we can't use PRNs at all, but it really is something that we want to be careful about because so many of the medications that we give are quite addicting. So we haven't talked about them yet, but we will. The benzodiazepines especially are very addicting. And so we really want people to try to use some coping skills before they get that PRN. And we want to remember that especially in moderate level of anxiety, we may have to repeat because they're missing key bits of information. Severe to panic, we may have to guide them, especially in severe. They may need step-by-step directions on how to even accomplish their ADLs. And in a panic level, we want to absolutely keep them safe. decrease that stimulation again, and make sure that we stay with them and that they don't harm themselves, because they really are at high risk for injury. Counseling, that is something that we as nurses can do. So that doesn't mean like a traditional counseling session that you would go to a social worker or a psychotherapist or psychiatrist for. It just really means talking to the person and helping them to problem solve and come up with ways to, to help themselves through these various situations. Teamwork and safety, we all work together as a team in mental health. We all hear reports on all the patients so that we know what's going on with everyone, so that if anyone on the unit sees something happening with a patient, we would certainly want to get that person's nurse right away, especially if somebody's having a panic attack. But if that nurse isn't around, everybody needs to know about that patient and to be able to work with them effectively. So we all pitch in and are using quite a bit of teamwork on the mental health unit. And the safety part too would certainly be assessing if somebody feels like harming themselves as a result of their anxiety level. We always want to promote self-care activities. So the interventions that we do, we always want to make sure that people are doing their ADLs. And you might think, well, that's very simple, and you might not even think that that should be a big focus in mental health, but actually it is. It's a huge focus, and it's very basic, but if you think again back to Maslow, what's on the very bottom of that triangle is basically, those very, very primary needs: food, clothing, shelter. So if people aren't, bathing, things like that kind of fall under that category. So if somebody is so anxious they can't even take a shower, we may need to really help them with those things. They're so anxious that they can't even sit down and eat a meal. They're not getting good nutrition. They're not getting adequate fluids. So promoting those self-care activities actually are quite important with this and all of the mental illness diagnoses that we're going to talk about in the future. Back to the case study, Anita recalls the help she experienced when she was treated as an adolescent for panic disorder. I remember my dad anxiously driving me to the emergency room while my mom sat in the back seat and held me, just trying to keep me calm. My dad gripped the wheel like he was afraid we'd go right off the road. So that just kind of brings up just another little aspect. Anxiety is actually contagious. Yes, it really is. Not in the same way that a cold or the flu is contagious, but it truly is contagious. If you've ever worked with a patient who is extremely anxious, all of a sudden you feel anxious. You can just feel their level of discomfort, and sometimes we pick it up because they may be very demanding. When they're very anxious, they may be wanting something and they want it right now because they're so anxious. And then that anxiety immediately is transferred onto you, and you feel anxious because you have to think about, okay, can I go and do this right now for them, or is there something else that I need to prioritize? So it really is contagious. So that's kind of what's happening in this scenario with the dad. When we got to the hospital, I remember a nurse came right out to the car and opened my door. She didn't grab me or anything. She just said, "Hi, Anita. My name is Betsy, and I understand from your mom's phone call that you're having a panic attack. I'm here to help you get through it." Then she held out her hand. I've always felt like Betsy saved me that night. So just again, that human contact, that nursing aspect of reaching out and connecting with somebody, that therapeutic relationship, and I'm here to help you. That's always a really positive thing to say in your nursing role. We don't ever want to say that certain things that are not therapeutic, like "I care about you," things like that, because really we don't know somebody well enough to have them believe that we care about them. But if you say, "I'm here to help you, I'm a nurse and I'm going to keep you safe, I'm going to get you through this panic attack," those are all things that are very, very helpful interventions. So, audience response question: what was probably the most helpful thing Betsy did for Anita that night? Left her by herself in a dark, quiet space to calm down? I don't think so. Stayed with her and kept up a steady stream of talk about anything at all to distract and soothe her. No, I think that kind of directly conflicts with what I just said about decreasing stimulation. So if you kind of constantly yak at somebody when they're anxious, you're actually increasing their stimulation and probably not making them feel better. Introduce her to a bright, pleasant game with other patients her age to create a much needed distraction from worry. No, not at that time. That is not effective because she needs that decrease in stimulation and that person to stay with her. So D, stayed with her in a quiet spot and listened, is absolutely the right answer. Okay, suppose you're a nurse or a social worker on duty when a child goes missing, but unlike Anita's child is not immediately found. Police arrive on the scene, the parent is questioned, and as the search intensifies, you are asked to remain with and take care of the anxious parent. What would be some appropriate interventions for helping a parent experiencing panic level anxiety? So I'm hoping that you're thinking about just staying with that person, not leaving them alone. Again, it's only going to last about 10 minutes or so. You might even reassure the person and say something like, "You're having a panic attack right now. I'm going to stay with you," because they might be expressing, if they can't express anything coherent at all, they may be expressing feelings like they're going to die. They really feel like something terrible is going to happen. They're going to pass out and die. And so you can reassure them by saying that this is a panic attack. It's going to, it's going to be over. Try to kind of, again, get their attention as their perceptual field widens, and it will eventually kind of get right in front of their face. Do some deep breathing with them, help them to breathe, just kind of show them, model how to breathe. There's all kinds of things that you can do that just really show that therapeutic relationship and that connection to help that person through the panic attack. And again, quiet, calm environment decrease that stimulation. So the implementation, pharmacologic interventions, we do have antidepressants that help with anxiety. There are other anti-anxiety drugs that are specifically meant for anxiety. There are other classifications also that, again, help with anxiety. What they're doing on 1K a lot lately is they are using medications. I got interrupted again. Anyways, I was talking about another medication that they're using quite frequently now on 1K rather than benzodiazepines because these medications are not addicting. So Atarax or hydroxyzine is a medication that we're using quite a bit for anxiety. Sometimes the orders will read that this can be given, the Atarax can be given PRN anxiety, but again, they usually want somebody to try like one or two coping mechanisms before you give the Atarax, and then if the Atarax is not effective, then perhaps you can give the benzodiazepine. Usually they give something like lorazepam as a PRN, so or sometimes Xanax, but again, a benzodiazepine. But this is a big change in practice, which is actually very positive because, again, benzos are addicting, and why get people addicted to drugs and dependent on taking medication for anxiety when there are so many different ways that they can use to reduce their anxiety level. So we do have to think about that classification. So psychobiological interventions, integrative therapy, health teaching, super important to think about the whole lifestyle thing when we're working with people with anxiety. We really need to look at the level of caffeine that people are consuming, if they're using any other substances like alcohol or even nicotine that can increase their anxiety level, if they're getting enough rest, if they're getting enough exercise. So we really do have to think about health teaching and just really trying to promote that healthy lifestyle. Something I just want to mention quick too is the second last bullet point talks about integrative therapy, and we don't have a signed chapter 35, but in your book on page 290 they talk about chapter 35 identifies a number of complementary practices or different types of integrative therapies. I'm not going to get into all of that. I don't have that chapter assigned, but just to know that be very careful to if you're recommending different types of herbal types of remedies for people because there are side effects that can occur. It's always good to find out from a patient too if they are trying any type of herbal or natural remedies to things because they may actually be conflicting with their medication. But we do use things like aromatherapy on 1K. They have lavender available, and I think bergamot. I'm not sure if they have any other. They might have peppermint. And those might just having, put a little bit on a cotton ball in a paper cup and the patient kind of gets some benefit from the scent. Things like that are perfectly fine. We do have to be, careful somehow, somewhat because of different herbals do have side effects. So what we should always be trying to do some kind of health teaching, again, in terms of ADLs, elimination, good sleep, good healthy basic living habits. Teaching is a huge part of our role as a nurse. So I think what I'm going to do is I'm going to end not this learning plan. I'm really tired, I guess, right now. So I'm going to end this recording right now because this recording is, gosh, it's almost 2 hours already. Okay, so I'm going to stop this one and I will begin another one very shortly.